Next, I'd like to share with you what are some of the ethical and practice concerns to keep in mind as you're exploring your work and your identity in integrative medicine for mental health. Ethics of nutritional and integrative medicine. Ethics in your practice of nutrition and CAM. Let's talk first about the scope of practice for integrative medicine for mental health. Your scope of practice in this work will be defined in part by your license or your certification. State laws generally govern your practice. Federal laws, for example, like the FDA, will govern the practice of cranial electrical stimulation, or the FDA will oversee labeling of nutritional supplementation. And so we want to differentiate between laws and national legal practice issues with state practice issues, along with your scope of practice in certification or licensure by your organization as well. And the FDA may regulate particular substances or materials, but they don't necessarily regulate your right to practice. So there are many layers to consider your own scope of practice and your own ability to practice. For example, herbal medicine is not regulated anywhere in the United States, though there are some practitioners who are trained, for example, licensed acupuncturists who are trained in herbal medicine as part of their licensure practice. The other thing to keep in mind in terms of your practice, and not only your scope of practice, but your clinical competency. So we're going to explore right now a little bit of the issues to consider, not only your scope of practice, what your discipline is, what's allowed, what's disallowed, what may be a gray area that hasn't been even addressed by your own ethics board or by any kind of resolutions, but also your competency to practice. Here's a photo image of the state laws that govern nutritional practice as of early 2018. And here you see the green states are where anyone can practice nutritional therapy. The yellow states are where there are different ranges of legal issues where you can do some practice and not other types of practice. The red states, no one but a registered dietitian or who is licensed to practice by the state can give nutritional advice. And so I've given you a link here to the advocacy organization that maintains this list. And the direction of practice is moving towards opening up practice and increasing the ability to practice nutritional therapies. This is the trend in the United States, though states vary widely, as you can see. So this is going to affect your own approach in this work. Much of what I will teach you during this course is under the rubric of psychoeducation. That means that you don't need a license to practice nutritional therapy or be a registered dietitian to suggest to a client who's anxious and has insomnia and can't sleep that maybe they should reduce the amount of coffee they're drinking. The Food Mood Diary is designed to do this, where you explore basic self-care issues that intersect with nutrition. Are you eating breakfast in the morning? Are you drinking a lot of coffee? Are you eating a lot of sugar? Are you drinking enough water? These are very basic self-care issues that come under psychoeducation. However, when you get into an area that we will explore later on, which looks at the role of amino acids, for example, 500 milligrams of D-L-phenylalanine twice a day to reduce pain, or using free amino acids, which will support 3,000 milligrams of fish oil along with borage oil. What is your level of competency to make those recommendations? What is your certification to do that? But also, what does your state allow? If you're in Washington State or in some of the Northeast states, you can do that. You be competent to do that after this course. You may decide to do an internship or training and get further training in areas that we haven't covered, and hang out your shingle and say, I'm going to do mental health nutrition. And if you're competent to do that and your state will allow you, then you can do it. Now, will your other certifying or licensure bodies allow you to do that? That's what you'll need to explore. So this is an essential area for exploring the ethics of practice as we move forward. And as I've talked about in my book, Nutrition Essentials for Mental Health, there are 3 broad ways to consider the practice that you'll do. You'll consider the psychoeducational approach, which is what I've just discussed. You'll also consider the collaborative approach. That's the approach where you know that your client will benefit from amino acids. When your client comes to you and says, my child's school teacher wants me to put my child on Ritalin and I don't want to, you're going to know, there are alternatives with diet and nutrients and botanicals. Let me refer you to a nutritional therapist with whom I collaborate, so that that person may come to you at first stop, but you know someone that you can collaborate with, you know the child, you know the family, but you're not going to be the person actually carrying out the recommendation process for nutritional change. This will certainly apply to the somatic therapies as well, or the herbal medicines as well. But then the final or the third level or tier of practice may be complete autonomous, independent practice, where both your state as well as your competency to practice and your knowledge base allows you to be able to make those recommendations. So think about where you are in your own training and competency right now, what your goals are for your niche practice, what state you live in, and what your particular interests are. And as we move through this course, you'll be able to explore this a little bit more deeply, and I'll point out to you what might be considered an initial psychoed approach as opposed to a more in-depth approach requiring competency certification or potentially licensure. Let's look at state laws governing touch therapies and somatic therapies in general. Touch therapies, massage therapies have both national certification, they have discipline-specific certification, and most states license the touching of clients. Now, some states differentiate between massage and touching clients with clothes on, clothes off. Reflexology may be licensed a little bit differently. The practice of the energetic forms, such as Reiki, may be licensed or regarded differently in the state rules. This is important to look at, but particularly in the role of touch, unless you're a body-oriented psychotherapist, unless you're trained and certified in touch, and then looking at the requirements if you have a mental health license. You'll want to understand the role and regulations of therapeutic touch. I'm not referring to, a hug or a gentle touch of the hand for reassurance. I'm talking about a therapeutic intervention. And when we look at the somatics module, I'll explore the range of touch therapies. You might want to look into the Body Association, Body Psychotherapy Association, which is an international association of body-oriented psychotherapists. Acupuncture is licensed both nationally, certified nationally, and then licensed by the state. It's licensed, also required a board exam. However, an exception to that is what's called the NADA, N-A-D-A protocol, which I'll explore later on. And this protocol was developed by Dr. Smith, and it's used as a lay-delivered protocol or an allied protocol. Many states will allow someone to be trained in the NADA protocol, which has a certification process, and be able to implement this protocol. It's auricular acupuncture, meaning the ear, the auricle, And it's designed particularly for the treatment of substance abuse recovery and alcohol recovery. Some states allow it, some don't. You may collaborate and have a NADA protocol practitioner work in your office or refer to someone. And then, of course, naturopathic therapies. Naturopathic physicians are both licensed and traditional naturopaths are certified. And each carries with it different capacities provided by state. There's currently no licensing or certification for herbalists. However, in the resource section, I provided you with the American Herbalist Guild, which is a source of registered herbalists, people who've reached a certain level of knowledge. I'm not going to suggest that certification or licensure even implies competency. We know that there are plenty of licensed and certified people who are incompetent, and we know there are plenty of people who are not licensed and certified who are competent. I think this is where it gets down to really identifying who you are, what your needs are, and also knowing who you are referring to. I think ultimately knowing people and word of mouth in terms of referrals is what makes most sense. And of course, licensure and certification intersects insurance. And while some states will pay for some of these interventions that we'll explore, most states and insurance companies will not. And so we'll explore when we talk about how to afford these approaches, different creative ideas that will make these methods accessible to everybody. So as I mentioned, your competency level, you've got your primary level, and that's when a combination of competency, credentials, and state laws allows you to fully integrate nutrition and CAM into mental health counseling. Your collaborative referrals is where you're working with or referring to a more advanced nutritional professional. You may do some psycho-ed with a group, or you may run a group with one kind of a licensed or certified professional, and you may provide the mental health and you may integrate that way. There's lots of ways to collaborate and refer, clearly, and this is a wonderful way to build practice and cross referrals. In terms of looking at your ethical requirements and your ethical self-review of your own competency, I ask you to ask yourself the question, am I competent to discuss or demonstrate these methods? Do I need additional training? Do I need certification or licensure to practice? Or do I refer or reach out to a colleague? So I think this is going to be a very personal decision for where you are right now and what your goal is for next steps. I'll reinforce throughout our whole training the role of nutritional self-care is psychoeducation. Nutrition is psychoeducation as we make linkages between what clients eat and drink and how it affects their cognitive and emotional well-being. We educate our client. There is a connection. There's so much today that works against making those connections, as though the body is off on its own doing something while the mind is elsewhere. Nothing obviously is further from the truth. So even beginning to educate our clients to pay attention to how their body, mind reacts to their behaviors, what they're eating, what they're doing, how they're exercising is a first step in our work together. Looking at the effects of nutrition behaviors on mental and emotional well-being. How do you feel after you eat a heavy carb breakfast? How do you feel after eating lots of donuts and coffee and not eating any protein until 1 in the afternoon? Any number of questions that explore making the connection and decreasing dissociation between nutritional behaviors and mental well-being is going to be an important first step in our work. I want to help my client assess their self-care nutrition routines. We're already looking at self-care, adding in nutrition, adding in, are you eating? Do you have access to food? We know poor food security or food insecurity is a risk factor for depression and mental illness. So understanding the situation our clients face, self-care behaviors in general, the social connection behaviors. Are you eating alone? Are you eating standing up? Are you eating fast foods? Do you have friends to prepare foods with? This is all part of our work in nutritional self-education. Knowing the literature and the clinical practice to provide options, even if you do not want to prescribe and recommend protocols. This is important. Understanding what the science says, understanding the options that are out there so that we can educate our clients and make those appropriate referrals. Ultimately, we're making the link between emotional nourishment and nutritional nourishment. This is nutritional psychoeducation. Let's look a little bit more deeply at differentiating your competency levels. One of the first interventions I'll teach you is, or assessments, is the Corn Food Mood Diary. This is a basic psychoeducation assessment that will illuminate quite a bit for you and your client. That's very different from reading a urinary neurotransmitter lab test. One is something you're ready to do right now. You can learn how to do it and get better at it as you practice. The other involves more training and understanding of urinary neurotransmitters. That's one way to differentiate your options. Assessing caffeine intake, sleep, and motivation is very different than, again, replacing coffee or caffeine with 500 milligrams of tyrosine. I want you to know that tyrosine at 500 milligrams twice a day is a good alternative to a caffeine addiction. But what is the state of your competency now or at the end of the course? Are you allowed to say this? Do you know enough to say this? This is another way to think about your own competency. Can you provide a recipe, for example, from my book, Eat Right, Feel Right, a mocha smoothie recipe to enhance focus? Yes, you can certainly share a recipe that's going to be filled with healthy foods and share that, or share a tea recipe when you might offer green tea or chamomile tea for your clients in your office. You might share the latest research on how eggs are so good for memory because they're rich in supporting the neurotransmitter acetylcholine. They're rich in choline. And so understanding the role of education and support is very different from prescribing. You're going to assess your competency and choose to enhance your competency at the stage and the rate and level that you wish to practice. This also brings us into the ethics of traditional medicine and cultural practices in the United States. And this all presents different ethical issues to us. In order to be culturally competent, in order to be compliant with our ethics requirements for all of our disciplines, we need to be culturally competent. I need to know about curanderismo if I'm working with the Mexican-American population in Yakima, Washington, for example. I want to know about Hmong shamanic practice if I'm working with Hmong individuals, people who were originally refugees after the Vietnam War and settled in a variety of communities throughout the United States. I want to know if my client comes to me and asks about, hey, I've heard about the use of ibogaine and it might help me get off of my opiate addiction. What do you think about this? I want to know that ibogaine is a substance that's extracted from the iboga plant from West Africa and is now being researched and used outside of the United States to decrease opiate addiction. And of course, native sweat lodge. A client may come and say, hey, I've got the opportunity to do a sweat lodge held down at the YMCA. I want to perhaps educate my client about concepts of cultural appropriation. Who's doing it? First of all, is it safe? But secondly, who's doing this sweat lodge? Is this cultural ritual being appropriated from indigenous peoples in a way that is culturally inappropriate? And so exploring this whole range and breadth of depth comes under the rubric of ethics and the ethics of practice of integrative medicine and cultural competency in integrative medicine for mental health. Let's take a moment to look at demographics, culture, and ethics. We've got about 34 to 42% of US adults use CAM. I've seen some research that takes it up to 65%. Depends who's doing the studies and when and how many are in the studies. Of the people aged 50 and older, 51% are women and 53% are men. 41% of people with liver disease tend to use CAM. Anxiety, depression, fatigue, and substance abuse. These are some of the major reasons why people use these methods. 89% of Hispanic and 81% of non-Hispanic white women in particular use herbal medicine. But the research shows that Hispanic women share this less with their providers. Almost 27% of children with pain use integrative and CAM methods. 57% of lesbians versus almost 41% of heterosexual women use CAM. 85% of women with rheumatoid arthritis use some form of CAM methods. And nearly 1/3 of these therapies were not reported to their health care providers, mostly because we don't ask. And so remember to ask and to reserve judgment on all of these methods. It is ethical. It's a requirement to ask about these methods. So I reveal my acceptance and knowledge of these approaches, and I ask about them in my intake, but also in my self-disclosure forum. I mention I'm very interested in spirituality. If you want to talk about it, religion, please share it with me. Let's incorporate it into treatment. If you don't, that's fine. If you're atheist, that's fine. I totally accept that as well. If you're interested in herbs, if you're doing a cultural ritual, please share this with me. I want to know what you're doing. I respect what you're doing, and let's make sure it's enhancing the whole program. This encourages trust and rapport. I want to ask, what's your use of CAM and other practices? I want to know if they're sharing the use of St. John's wort, for example, an herbal SSRI, with the prescriber who prescribed fluoxetine. I want to know who the CAM support team is. Let's bring people together. The integrative process of practitioners is only going to reinforce the internal sense of integration and self-regulation. I certainly want to do a drug nutrient herb analysis with a database. There are certainly good books out there, but I use online databases to run some of these interactions. And then we know that doing this, asking about these methods, enhances efficacy, enhances rapport, and it decreases compartmentalization and triangulation. I want to identify medications that have been prescribed. Let's identify medicines you're taking. And where did you learn to take this? How many prescribers do you have? Or did you get something off the internet? I'm going to ask about dietary habits and the use of nutrition and herbs. I want to know about the individual's concept of illness. What do they believe about their illness? For example, we have so many beliefs about getting a cold. Some people believe that someone sneezes and you've been exposed to the virus. I have clients who believe that a cold wind blew through and it brought a mal aire, and that exposed them to getting a cold. Some people believe getting your feet exposed to cold water makes you vulnerable to a cold. In Chinese medicine, there are so many beliefs. And may I suggest that the germ theory is just one more belief about what causes illness. So I want to explore the meaning of illness in the context of culture. I want to explore medication characteristics, the side effects people may be experiencing. We know that many people don't adhere to medication protocols because of side effects. Can we ameliorate those? Later, I'll teach you how to add in certain nutritional and botanical supports that will allow the reduction of dosage by the prescriber. and how to get adherence by the prescriber to this approach as well. And then, of course, understanding the symbolic power and value of medication in the patient's life and in their culture. Ethics, the practice of CAM and culture. Our codes mandate cultural competency and cultural awareness, and also becoming aware of the transnational health practices and the provider networks, which are very large and well developed in the United States. This refers to people living in the United States who maintain ties and connections with relatives and friends in their home country. And this may involve the transfer of medicines, of botanicals, and even of foods. There's an awareness of how culture informs and also defines our diagnostic and treatment categories. And recognizing our own biases in this area is essential to competency and efficacious practice. Traditional medicine. Traditional medicine is defined by the WHO as the sum total of the knowledge, skill, and practices based on the theories, beliefs, and experiences indigenous to different cultures. Traditional medicine is practiced by 80% of the world population. And if you're working with people who've migrated, who are immigrants, who are refugees, or also people who adhere to cultural practices, you are going to be coming across traditional medicine practices. And I think it's worth exploring. Traditional medicine also intersects cultural concepts of distress, ways that cultural groups experience, understand, and communicate suffering, behavioral problems, or troubling thoughts and emotions. Now, this area is where we begin to get into a little bit of what I think is the best part of the DSM-5, which is the cultural formulation interview and the intersection of culture and mental health. So I ask you right now to consider what you believe and why. I mentioned before, you caught a cold or headache, you're depressed, you can't sleep. The reasons for all of these vary across culture. What we tell ourselves about why I have a headache, why I can't sleep, this is very unique to cultural interpretations of distress. And our response and how we teach and treat about this comes out of our own, often cultural ideology, our own belief system. And this can veer into dangerous areas where we can project a pathology onto someone who believes something is caused for a different reason than we do. And I'll talk more about that in a moment. So these reasons vary across culture, they vary across religions. All forms of distress are shaped by local cultural experience. And this is where the cultural formulation interview gives us a wonderful assessment by which to ask questions in culturally sensitive ways to explore this with everyone in our practice. The cultural formulation helps us adhere to culturally competent practice. It's a semi-structured interview. It's designed to assess cultural factors at work in our clients' lives. It focuses on the individual's experience. It's person-centered, and it's designed to avoid stereotyping. So even if we're not familiar or feel at ease right away with asking some of these questions, the formulation is a very simple guide that has very profound consequences for connecting with people across different cultures and different belief systems. And let me reiterate that it's designed for use with everyone. It's not the other person that has a culture. We all have a culture that informs our beliefs. The cultural formulation modules, the CFI modules, provide a variety of modules that help us explain or have an explanatory model. They help us define level of functioning, social network, psychosocial stressors. They help us explore spirituality, religion, even moral traditions, cultural identity and to what degree it's important or not, coping and help-seeking behaviors, the patient-clinician relationship, which I think is all important, because the patient-clinician relationship is very much defined by cultural mores. I had a wonderful opportunity to travel and teach in Cuba last year, and I was so excited and thrilled to be invited into a psychiatric clinic where one of the treatments for everyone at the hospital every day was to spend an hour in a large gymnasium with the psychiatrists, the nurses, the mental health counselors, and the patients all together, holding hands, dancing together, listening to music and going through ritualized form of dance. And I thought, you would never see this in the United States. You would never see clinicians and patients holding hands together in a public health hospital, dancing together. And so our ideas about treatment are informed by our beliefs about illness and our beliefs about the nature of what is an appropriate clinician-patient relationship. School-age children and adolescents has a module to explore, older adults, and there's also a module where you can ask the caregiver in case the client herself or himself is unavailable to answer, or you want secondary input on the knowledge base. And then, of course, in immigrants and refugees exploration. So the CFI interview is designed to explore culturally based issues with flexible language. It's not rigid. You can adapt it the way you need to. It addresses concerns and beliefs about the course of the illness. Are you concerned about it? Are you hopeful about it? It provides language to explore these issues of culture and religion, and of course to explore traditional medicine practices in a very culturally sensitive way. Culture, stigma, and mental health. We know that there's a lot of stigma across cultures about obtaining mental health support. CAM and traditional medicine use is high across cultures and ethnic groups. I have found in my own work that framing the physical is a wonderful non-stigmatizing doorway into exploring mental health. People tend to be more willing to talk about aches and pains and physical distress rather than emotional concerns. And yet once we explore the physical, we can gently tread into the area of the emotional. I find this to be very effective working with people where it's a stigma to admit to mental illness. Now, I come from an area, from Boston and a suburb where it's a stigma if you haven't been in psychotherapy for 5 years. So I was quite surprised when I moved west and discovered there was a lot of stigma across a variety of groups about just admitting to mental distress or seeking counseling. And so the work that we're exploring here in integrative approaches, culturally informed approaches, gives us a doorway through the physical to decrease that stigma, and I found it to be very effective, and I encourage you to explore this working across different cultures. Questions about stress are almost always universally acceptable. Digestion, sleep, and pain. These are questions that people readily respond to, and yet are really an entree into exploring some of the deeper issues. CAM is cross-disciplinary and cross-cultural. Mental health providers learn how to integrate a physical health history. Physical health providers integrate a mental health history. For example, the ACE score is being used more widely these days. There's an effort in our public health system for physical health providers to ask the ACE questions, to understand the role of adverse childhood events in acute and chronic physical complaint. And we know that is the core of why people seek physical and emotional help, is the ACE experience. We want to identify and treat the intersections of trauma, pain, chronic illness, substance abuse, even surgeries, multiple surgeries, and the addiction to surgery, along with poor sleep. If we can address these underlying issues, we're going to, whether we do it in our own practice or cross-collaborate, we're going to have very profound effects on the overall success of our work. We know that to be a minority in the United States is often to experience discrimination, which leads to stress, leads to inflammatory process, depression, poor sleep, diabetes type 2. That's one such progression. So we also want to be culturally competent in considering the social milieu in which our client is living and existing in terms of what it means to be a person of color or minority status in the United States. It often means discrimination and living a vigilant life. This is where our work in terms of integrative medicine, CAM, intersects culture, and perceived racism. And this has to inform some of our interventions and our cultural competency. We consider the accumulation of physiological wear and tear as the effects of chronic stressors in daily life. This is a definition of allostatic load. We know that racism is a stressor that leads to chronic autonomic arousal. This is going to affect, as I mentioned earlier, digestion, depression, hypertension, diabetes type 2. It's going to exacerbate and enhance self-medication behaviors. We know, for example, that African Americans have an earlier mortality compared to whites in the United States, hypothesized to be as a result of chronic stress and its effect of allostatic load leading to chronic illness. So an important culturally competent intervention is to screen for allostatic load. And I'd like to introduce you to some of the screening methods for allostatic load. And why is this important? Not only as a baseline to support our clients, but integrative medicine is ideal for decreasing stress and decreasing allostatic load. We've got a lot of answers for this. Integrative medicine for mental health, allostatic load screening. There are both physiological and psychological indicators to screen for allostatic load. Perceived discrimination, and I'm going to introduce you to a perceived discrimination scale shortly. Poverty is an indicator and a risk factor for allostatic load. The ACE score, as we well know, is an indicator of exposure to chronic stress and increases allostatic load. 24-hour cortisol. 24-hour cortisol is a biological indicator of stress. It's an indicator of one's alignment with the 24-hour circadian rhythm, our sleep-wake cycle, the light-dark cycle. And this is both governed and entrained by hormones, cortisol. And so we can affect cortisol not only through lifestyle intervention, but through nutrition and botanical intervention. So this is an indicator of allostatic load. For example, if I have a client with very low morning cortisol and very high evening cortisol, that's a biological indicator of depression, and I need never even meet that client. And I will know that they have biological depression just by looking at the disruption of their cortisol flow. HbA1c, which is the average of blood glucose over time. If it's high, then it means that they are often insulin resistant, their blood glucose is high, and maybe they've moved from functional hypoglycemia, or they may be at risk at diabetes or even have diabetes type 2. Heart rate variability, a very conventional 24-hour indicator that's measured by a Holter monitor in cardiology, is an early indicator of autonomic stress. We can often catch heart disease by looking at the Holter monitor before it manifests. And then C-reactive protein, and this requires what's called a sensitive C-reactive protein test. This is a blood test that measures inflammatory process in the body. This is a conventional measure of inflammation and heart disease risk, but we know it's a general measure of inflammation, which we can affect positively through changing diet and nutritional implementation. I provided you here with some references on emotional stress, discrimination, and health. Let's talk about ethnicity, complementary alternative medicine, and sleep. Sleep health can be supported by CAM and CBT to modify a range of physical and emotional health challenges. This is also an important intersection with culture because research shows that African Americans get less sleep than white people. It is hypothesized this is due to the stress of vigilance, the stress of being on guard, the stress of discrimination in US society. We know that people with an ACE score of 4+ have poor quality sleep. They have less slow wave, less restorative sleep. They're often sensitive to stress. This results in fatigue. It exacerbates insulin resistance. And so this gives us a lot to work with because we know if we can restore sleep, if we can help people sleep better, have more quality sleep, then we're going to help people improve their mood, improve their physical health, and improve their emotional health and well-being. Some of the interventions I suggest: integrative assessment and clinical intervention, screen for sleep in every assessment, identify the types of sleep disruption your client experiences. I've given you the Insomnia Severity Index, and of course the Pittsburgh Sleep Quality Index is ideal. And the brief hypervigilance scale is often helpful as well. We don't tend to ask our clients these questions, but why not? Clients will not raise their experience of discrimination with us necessarily, and so let's proactively ask about it. I've given you here a photo of blue light blocking glasses, and as we discuss light therapies and dark therapies for sleep, we'll explore this more. But I encourage you to explore blue light blocking glasses to help re-regulate circadian rhythm. It helps sleep at night. Indeed, it's the opposite of why we do light therapy for depression or SAD or for bulimia. The use of blue light blocking glasses at night will enhance serotonin release and enhance sleep. So explore these inexpensive tools for you and your clients. How do we make meaning, our own meaning making? The consensus trance is a concept that the experimental psychologist Dr. Tart has explored quite a bit in his work in parapsychology. Howard Rheingold, writing about Dr. Tart's research, suggests together human groups agree on which of their perceptions should be admitted into awareness, hence the consensus. And then they train each other to see the world in that way and only in that way, hence the trance. This goes back to the concept I was mentioning earlier about how culture informs what we believe about illness. It informs the meaning we make about illness. It informs our beliefs about diagnosis and treatment. And I would love for you to go with me for just a 5-minute tour through the last 2,000 years to give a few examples of how culture informs our beliefs about the cause of illness and then the treatment. Hysteria in ancient Greece. The hysterical woman was considered paralyzed in her throat because the uterus, called hyster, the Greek word for uterus, was believed to have become dislodged, traveled up her thorax, and become stuck in the throat. Hence, the idea of hysteria and the hysterical woman. And lest we think that that is a quaint, silly concept of the Greeks, some of it still in vestiges remains with us even today. Let's go fast forward to Sigmund Freud and his work on the Oedipal theory. Dr. Freud gave us so much insight into the role of the unconscious. And indeed, Dr. Freud discovered in his work with his patients, both female and male, that the cause of their distress was indeed the fact that they had been sexually abused as children. However, Dr. Freud, as a Jew and as a neurologist, a psychiatrist, on the lowest echelon of society in Victorian Vienna and Austria in Germany, was told, give up that idea, Dr. Freud. You'll never make it in your career. Let go of it. It'll never be acceptable. And seeking acceptance, Dr. Freud turned to the fantasy of sexual desire, the fantasy of the Oedipal complex, which indeed's never been proven and indeed is an archaic concept that in its effect lost 100 years in the advance of our understanding of the role of sexual abuse in childhood and its effects on psychopathology and distress in both children and adults. And so the very powerful effect of culture, meaning making, and pressures on diagnosis and interventions persisted after Dr. Freud. Not long after this, during World War I, we see here an image of shell shock. And in World War I, what was called shell shock, what we now call PTSD, was considered an illness that happened to homosexual men. Sissies, they were called, or latent homosexuals. And they were sent right back to the front to go to war, to man up. And so this concept informed not only treatment of men and veterans in World War I, but we still see the stigma of seeking help due to PTSD, due to war today in treatment. How about the 1950s and the transorbital lobotomy procedure, where it was believed that you just jiggle that frontal cortex and reduce psychotic symptoms, and we know the disasters that that led to in the lives of patients. 1960s, the refrigerator mother was believed to be the cause of autism. The cold, uncaring mother. How many lives were destroyed telling women that their treatment of their children caused autism. It took many years for the DSM to relinquish the concept of homosexuality as a pathology. In the DSM-1, it was called paraphilia. The 2, it was sexual orientation disturbance, and then DSM-3, ego dystonic homosexuality. It took until not that long ago to release that, and we still are challenged with clinicians and religious adherents who are trying to conduct conversion therapies on people, both male and female. What are our controversies today? Some of the more recent controversies. Gulf War syndrome, when men and women came back from the war with chronic physical problems, they were told it was all in their head, and it was only recently that it was identified as exposure to toxic chemicals. ADHD remains an unproven diagnosis and the subject of a lot of controversy, and we'll explore integrative approaches for the treatment and the support of term I prefer to use is focus and cognitive function. How has ADHD diagnosis increased at a time where the use of good quality foods and decrease of arts and physicality, exercise in the schools has decreased? Fibromyalgia, many years ago, it was considered a predominant diagnosis of women. and women were told that it was an emotional form of distress. We understand now it's a very complex dysfunction of the HPA axis, the immune system. It's a sleep disorder. Mitochondrial dysfunction is involved. Integrative medicine lends itself very well for support of fibromyalgia, highly correlated with exposure to complex trauma in childhood. The serotonin theory of depression, never really been proven, a subject of a great deal of controversy. My pet peeve, borderline personality. Is it borderline or is it complex trauma? Borderline remains often used as a pejorative term. The inability to self-regulate, the so-called neediness of these clients. We see almost 100% rates of some kind of high ACE score complex trauma. My preference is identify what the cause of the behaviors is. If we do, we get the results. And then there's the controversies around vaccine use and autism, which remains an ongoing controversy still that is affecting people in a variety of ways on both sides of the discussion. I think the science still remains to be elucidated. There's some very interesting work looking at this concept that it's a huge environmental load, and vaccines may play one small part with some people in a role of environmental stressors in these individuals' lives. So how do our beliefs about diagnosis affect our approaches to treatment? How do my beliefs as a clinician affect what I'm going to offer my clients? How do we expand our options to address the diverse and changing needs of our clients? And I provided you with a resource here, the model guidelines for the use of complementary and alternative therapies put out by the National Institutes of Health. So in summary, we've explored today the ethics of CAM practice that includes awareness of federal and state laws when you practice, the ethics that includes awareness of your scope of practice. Are you licensed? Are you certified? What does it mean to be clinically competent in this area? I've looked at nutrition for mental health as psychoeducation at the basic level of competency that's open to everyone. The ethics of practice ask us to explore our own belief systems and cultural context. The ethics of practice asks that we explore with our clients their own beliefs, their practices without judgment. The value and role of the DSM-5 cultural formulation interview that helps us bridge culture and cultural competency with asking sensitive questions about spirituality, traditional practices, medicine practices and rituals. And then the ethics of this practice asks and requires that we explore the complex interplay with physical health, mental health, and ethnic identity. Thank you.